Okay, welcome back. We will start with the feet now. The anatomy for joints are exactly the same, whether it may be the hand, feet, or spine. So it's exactly the same principles apply. So this is the ankle joint.
No, no, please. Turn off on the speaker.
So we'll talk about first the ankle joint, which is the most important joint and most prone to injuries, and people who play sports. This is the joint which is most commonly affected. So just looking at this is again, if you remember, this is the epiphysis, this is the articular surface, adjacent to this is meta, and above that is di. This is the distal part of the metaphysis. If you go up towards the hip joint, it becomes exactly the same, the physis and the meta, and then joins with the diaphysis. So diaphysis, when I say, is the shaft of whatever the long bone is, and the expanded end becomes the metaphysis. So this is the medial malleolus. The fibula comes down, becomes expanded, it becomes the lateral malleolus. The medial malleolus and the lateral malleolus articulate with the talus. I haven't got the anatomy of the talus in detail, but we'll see if we can go through the details, because this is very important, and most of the injuries, either it may be impacted, OCD, or injury trauma, and what Gopi showed, the os trigone, is also depending on the age of the patient. So the articulation is, this is the medial malleolus articulating with the medial process of the articular surface of the talus, and the fibular lateral malleolus articulating with the lateral process, articular process of the talus. This is the lateral projection. Okay. Lateral projection, again, that's the fibula, that's the tibia. Oh, sorry. So if you look at it, so I can probably tell you some anatomy of the talus. So that's the articular surface projected to the medial side of the joint. So that's the talus, that's the waist of the talus, that's the anterior projection of the talus, that's the posterior projection of the talus. So anterior has got an articular head which articulates with the navicular. Calcaneus, again, on the medial side is fans out, becomes the sustentacular tali, and posteriorly it forms the body and the calcaneal surface, that's the heel. That's the articular process, and articulates with the cuboid. So always remember, CC is the normal, mnemonic to remember. CC is the calcaneal articulating with cuboid, talus articulating with the navicular bone. The anatomy is very important for feet, if you are doing spec CT, and you need to know what is the exact anatomy so that you can localize the abnormality. You see these projections here. You've got two projections posteriorly over the talus. One is the medial, towards the medial side. This is most likely the medial tubercle of the talus, or medial projection of the talus, and there will be one on the lateral side exactly the same. That will be the lateral process of the talus. What Gopi showed you here that was hot, that was os trigone. Os trigone is an ossicle which fuses with time and becomes ossified, and it becomes one part of the talus. If it doesn't, then it stays as trigone, os trigone, and it is prone to injury and inflammation. So bones, you've got 26 bones in the feet. We say hind, mid, and fore. So hind foot is talus and calcaneus. So talus and calcaneus up to here is the hind foot. Midfoot is the navicular and cuboid. So this two parts is mid. So this is the mortis. Mortis is the tibio-talar joint, and this is talus. So below talus is subtalar joint. This is midfoot. So midfoot is cuboid, navicular, and three cuneiform: medial, intermediate, and lateral. So this forms the mid-tarsal joint. Yeah, and these are the forefoot, so metatarsal bones and the phalanges. So joints forming from here. So this is talus, that's the calcaneus. So calcaneus articulating with the cuboid, CC, talus articulating with the navicular. You can see the different morphology of these two bones, cuboid and navicular. I get most of the time confused when I'm looking at the spec CT. So I need to adjust my brain, what is the medial and what's the lateral. So this is the thumb. So navicular is towards the medial side and calcaneus is towards the lateral side. And it is a sort of rectangular shape or cuboid shape in 3 dimensions. And this is flat, sausage shape, and it's navicular. Now looking at this, so talus articulate with navicular, navicular articulates with the cuneiforms. So you see the medial, intermediate, and lateral cuneiform. And then lateral cuneiform articulates with the cuboid, and cuboids articulate with the calcaneus and as well as the navicular. This is very important. When you're looking at the spec CT, you see uptake, then you need to define the anatomy, whether it's degenerative or whether there is pseudoarthrosis, because most of the patients will have had fixation of the joints either with screw or nails or something else, surgery, osteotomies. So you need to describe where the abnormality is, where the abnormal uptake is, and where you see CT changes. So it directs the surgeons where to intervene to relieve the pain. So if you're looking at this, the cuboid articulating with the cuneiform, so it becomes one line, and these are the transmetatarsal joints, all these. So if you see the fourth and the fifth articulating with the cuboid, and if you see this is a process of the fifth metacarpal, which is likely to and most likely the site of injury. So you see uptake here, so it's most likely associated with fracture, and it's majority of the time it's either when the person falls or has inversion injuries. So there is a ligament peroneus attached here. So if normally it was, because this is the physis, it articulates and fuses with the body of the fifth metacarpal, and this line is prone to injury because the attachment of the muscle here, when it strains, it pulls on this, and it was the joint here. So sometimes you need to be careful if you're looking at the feet of a child. You see a lucent line on CT, which could be non-fused epiphysis. The epiphysis will be always like this, and the fracture will be always like this in this plane. So looking at this, now you've got the cuneiforms, the medial cuneiform articulating with the first metatarsal, and then second articulates with the medial, intermediate, and a bit of intermediate. So you need to be aware of these articulations. And then you've got metacarpal articulating with the phalangeals, and these are metatarsophalangeal and interphalangeal. joints. This is just another projection. So you've got talus, calcaneus, cuboid, cuneiforms, metatarsals, and phalangeals. This is basically a projection from the medial side. So if you look from the medial side, if you are looking at the spec CT and you're looking at the sagittals, so sagittal will show an image. So you need to be aware when you're looking at the spec CT what projections and how you want to evaluate a ankle or whatever joint or whatever bone you need to look at. I prefer looking at in the sagittal first and then probably go into axials and then correlate with the coronals. So if you see this sagittal projection, it's medial projection. So you've got calcaneus in line, talus, and then you get navicular. You don't see the other bones. And you see the first cuneiform and first metatarsal. And if you see the lateral, you have got calcaneus and cuboid come into place. And then you've got these metatarsal, and you see third, second, and a bit of navicular. It depends on how you have angled it. So you've got the talus there articulating with the calcaneus, subtalar joint, and then you've got the space, a tunnel is the tarsal tunnel. The other important component of the ankle is the deltoid triangle. So you've got this tibia, you've got the process here, malleolus. So it basically joins a fixed, rigid stabilization here. You've got talocalcaneal, tibiocalcaneal, and probably tibiotalus and tibiocuneiforms. So it's a rigid. So if you, this is most likely associated with sports injury or twisting, inversion injuries, especially if you are skiing and if you're playing football. You can injure this and you will not have any fracture, but you have severe tenderness, unable to stand, bear weight, and this is most likely. So most of the time, if you take your child or if you take, if you injure your ankle, you go to A&E, they do the x-rays, nothing there, they say this is most ligamentous injury. So this is most likely a ligamentous injury which causes severe pain. I don't want to go into all details, but any bone where there is disruption is always associated with avulsion of these ligaments. This is the plantar fascia. This is the attachment of the Achilles. So what Gopi showed you, you need to know your anatomy well. So if you look at the, I'll talk about Achilles. So Achilles tendon is a muscle, and then it comes down and becomes a tendon, and it attaches to the calcaneal process here. So it is just here, it stops and fuses with the bone. On the other hand, the plantar is on the plantar surface, arises from the plantar tuberosity, and is on the sole, on the plantar surface of the calcaneum. So that's the difference. If you look at the image, what Gopi showed, you will be able to appreciate, but again, it's difficult unless you look at the spec CT, because you can have bursa here, and that can be bursitis. Again, this is the lateral, this fibula, calcaneal, fibula talar, and fibulotibial joint. So it's all basically joined together in a fixed, rigid situation. So this is what we have already discussed. So the articulation between the talus, navicular, cuboid, cuneiforms, metatarsal, metatarsophalangeal, and interphalangeal joints. So again, these are the sesamoid, which are very important in the feet. They can be inflamed, they can fracture, so it is very important. If you see uptake, you just don't just disregard it, or this is a sesamoid bone, and you just ignore it. You have to look at it and you see whether there is a fracture, whether there is inflammation. Sometimes there are two or there can be three. So this is not a fracture, these are two. Why this is not a fracture? Because if you go on to CT, you see a well demarcated area with sclerosis. If you've got sclerosis, then you are safe that this is not a fracture, it is probably two separate bones. Again, looking at the anatomy is exactly the same as the hand. You've got space, joint space, you've got the cartilage, and you need to look and describe the articular cartilage, joint space, and whatever the joints are involved and the pathology related to it. So looking at the CT, so this is how it will be. You'll have axial, coronal, and sagittal. So again, it shows the articulation. So you have got the tibia here, you have got fibula here, and tibia articulating with the talus. This is the superior articular surface, that's the dome of the talus, and that's fibula articulating with the talus, and this is the medial malleolus coming down and articulating with the talus. Talus is articulating with the superior articular surface of calcaneus. So as we go along, again the same. This is talus and calcaneus with the medial side, and now you've got navicular coming with the. So you know that's navicular. You know that this will be talus articulating. You know this is calcaneus, and this will be articulating with the cuboid. So as you go along further distally, then you have got medial cuneiform, you have got intermediate cuneiform, you've got lateral cuneiform, then you've got, I showed you that with lateral, the cuboid, the shape of the cuboid, and the first metatarsal come into place. So again, it's very difficult on single projection. If I tell you what this is, it becomes difficult. Even if you ask me, it will be very difficult. But as you go along slice by slice and looking at the proximal to distal, then you will be able to identify the anatomy. If you just give me, I'm reading what's written here. Some of the bones I know, but some of them which are appearing is difficult because it's one slice after the other and it's not in continuum. So again, the important thing is you know this, what it is. This is the medial cuneiform, this is the intermediate and lateral. So this is the bone which is coming in, which articulates with the lateral, intermediate, and medial cuneiform. And this is the second metatarsal coming in, along with the third, and then as you go along, it will be fourth and fifth. But if you look at this, this is basically articulating with three bones, and if you have got changes or a fracture, all three joints will be, bones will be affected. So this is very important when you are describing on your spec CT that what joints are involved, because you can say, if you see uptake here, because it will be very nice and very colorful when you're looking at the spec CT, you've got fused images, you know what the active disease is and what is the silent disease. So you need to tell them that this is the joint which is affected, even though you know that the second metatarsal is articulating with three bones. But you say this is the lateral side, this is the medial side, so the lateral part of the second metatarsal articulating with the lateral cuneiform is degenerative and is active osteoblastic activity, so suggestive of the focus of the points of pain. So they can either go in and inject at this point, or they can go and fuse this if it is continuous and it doesn't resolve with injection. Again the same. Now the first metatarsal is coming in. This is again three cuneiforms, and this is the fourth and the fifth metatarsal. So we'll just skip this. So this is the sagittal view. So again, this is very nice. So as I told you, if you go along this, you've got this is talus articulating with the navicular, articulating with the medial cuneiform. So this is the medial side, and you see the heel there. So that's the part of the calcaneum. This is the part of the calcaneum, proximal and distal part. and this is the sesamoid. So if you look at the sesamoid here, uh, people, ladies who wear high heels, they are prone to this degenerative changes with hallux valgus, the deviation of this joint towards the lateral side, so this becomes prominent. There is thickening of the bone, and sometimes it gets inflamed, and then this causes bursitis and causes inflammation of this bone. You need to be aware whether this is inflammation or there is a fracture. If you look at this, you have got very well defined delineated margin, cortical margin, and you see the soft tissues around. This is a bone window, so you don't see the soft tissue, but once you have seen this bone in the bone window, then you go back and look at the soft tissue. So soft tissue, basically the gray part, the dark gray is the fat. The lighter gray is the muscles. So you see the differentiation, and you see a clear outline on CT between these interfaces, and if they are obscured, we say stranding. So stranding terminology reflects there is some water, fluid, or inflammatory infiltrates within the soft tissue, and that reflects inflammation/infection. So when you are looking at this, somebody asked me about how would you know, or somebody asked, go for me, I don't remember. If there is a joint which is inflamed or infected and there is loosening, how would you differentiate whether this is just loosening or this is infection? So if you look at it, I don't know whether I've got knee joint CT, we'll have a look. If you look at this joint, this is the mortise. Look at the soft tissue here, look at the soft tissue here, and the fat. You've got a planes well demarcated, well outlined. These are the anterior compartment, and that's probably tibialis anterior coming in. And this is the posterior part, and probably brushing through the medial part is maybe a tibialis posterior. I may be wrong, but I think this runs through and attaches here. So that's tibialis posterior. So they've got a fat plane, they've got a fat plane here. So if gets on plain film, this gets elevated if there is a fracture. So that's why you see ancillary findings on plain film. If that is distorted, then that means there is something wrong. CT is good, you look at it, you see whether the cortex is intact, there is no fracture. But if there is swelling of this, loss of this grayness, and it becomes similar to this, then you say there is something wrong, there is possibly inflammation in the joint. And if the patient biomarkers are raised like CRP and white cell, because if they haven't given you the history that the patient is febrile, patient has abnormal markers, then you don't know. You will say maybe, maybe not, depends what the patient has had. But if you have got the biochemistry and the history, then you can say this is most likely septic arthritis. If you say that, then basically it's a red alarm for the clinician, and they need to intervene ASAP. So this patient needs to go to theater and needs washout or needs to be put on antibiotics. So again, now looking at the talus articulating with the inferior surface, that's the subtalar canal, talus articulating with the navicular and medial cuneiform, and then the first metatarsal. So, but it's easy if you go along and you follow the bones, you know what is articulating. So talus articulating with navicular, calcaneus articulating with the cuboid, and then you have got the lateral cuneiform and intermediate cuneiform coming in. Again, similar appearance, but more defined bones coming up as you go along, slice by slice. And this is basically calcaneus articulating with the cuboid. So coronals, again similar. You've got, you just need to identify these bones. So these are the lateral malleus, medial malleus, talus articulating with tibia, articulating with talus, talus articulating with navicular, navicular articulating with these cuneiforms. And again, so you've got cuboid shape, so cuboid bone, flattened, navicular bone side by side, and then in between these spaces you've got medial, intermediate, and lateral cuneiform, and then metatarsals. Similar. Okay. Gopi showed you some of the coalitions. So the most common is Tarsal Calcaneus. Here it's a bit difficult for you probably, but if you look at this, you've got a C. Can everybody see that? So that's the outline going through. So that's a complete C. When you see that on a plain film, that means it reflects there is fusion of the talocalcaneal joint, and this is talocalcaneal fusion. It's not clear, but when you are looking at the spec CT, you need to look at it whether there is fusion. Fusion could be bony, could be fibrous, it could be mixed. If you've got solid fusion, bone are fused, probably this one is bony fusion, that's why you see it on X-ray. It's calcified, so it's solid fusion. But if the patient comes back to you and says that the clinician says that there is still pain, and this could be congenital or this could be surgically introduced because of the persistent pain, and they fix it and they articulate and fuse it. So this is what it is. This is a space. You can still see the space. That's the talus. So you've got fusion here. There's loss of space, and then you have loss of space here. So this is talocalcaneal fusion. There's another projection. So that was posteriorly fused, and this is anteriorly fused. See, this is one. There should be a joint here, if there isn't. So that's the talus articulating with the navicular, and that's the calcaneus articulating and fixed with the talus. There's another projection. So here, if you look at it, and if you look at this, you don't know that which is the painful area. You will report this as there is collision, there is solid collision, and there is bone formation, but the supralaterally there is still space. So this could be a fibrous fusion, and this may be mobile, or this could be biomechanical, because this is fixed and there's movement still present there. And there, if you do a bone scan, you will see activity there. So maybe this is because incomplete fusion, if this is basically surgically done. If it is not congenital, then it could be partial or incomplete tarsal collision. So this is very important. Then you have to describe that this is solid fusion. You see callus formation, you have got solid bone, but there is low density area seen between the joint. The joint is still maintained, and then the cortex, the black line is the cortex, so that's the cortex, and you can still see the space. So but there is uptake, so this means there is still movement, and that could be the pain generator. You need to direct the surgeon so that they can make a decision, and they can decide whether they want to go and put screws in and fix this. Yeah, that's the joint space, and that outline is the cortex, or the interface between the cortex and the fat. No, the thing is, if there is any intervention, does you talk about fusion. Congenital is coalition. Yeah, so basically if you talk about tarsal metatarsal collision, collision is fusion basically, but then when you're talking about post-surgical, then you say there is incomplete fusion, partial fusion, or complete fusion. So if you say partial fusion, then you have to describe what part of the fusion is complete and what part is incomplete, because that is the most important. Probably I think I've got for spine, it's exactly the same. When they fix it, that is the main problem: what has been solid, what has been incomplete, and then you need to look at it with the background of metal, and then you need to tell them whether this is the area which is causing problem. Yeah. If you now look at this and compare with the other one which I showed you here, you lose the outline here, and here you have got still that joint. The joint goes here, but you see a beaking here. When you see this beaking, this always reflects. This is calcaneus, and it is going towards the medial side, and this reflects Calcaneonavicular coalition. Yeah, understand? Easy. So just remember. So basically, you need to look at this. Is I'm showing you is easy on the plain film. CT it becomes difficult because slice by slice. So when you're looking at a spect CT, you go through. If you're looking at axials are the best or sagittals are the best, but sagittal you lose the line, but axially you go through the joint in line. So it's, you look at this, you see the space, you say it's fine, okay. Then you come into the subtalar joint, and then you look at the subtalar joint. If you see the space, you're fine. But then you look at the talonavicular joint, you see the space is fine, that the talonavicular is fine. But here, because the way it's being projected, you can't see the collision. But if you see this beak, this is not abnormal. The articular surface of the calcaneum should be like this. Yeah, but this beak goes into the naviculum because on the medial side, and is articulating and forming a bony bridge. So this is calcaneonavicular coalition. You can see it here. Yeah, so you still see a line there, but it's not complete. But there is suggestion of coalition there. Yeah. Now you see this one. You've got coalition here, and then you look at this, and there is erosion, irregularity, and sclerosis. You can argue that this could be Achilles tendonitis causing this, but if you look at this, this is the Achilles tendon coming and inserting here, because this density is the tendon. And this erosion is writer's disease. Writer's can involve the feet and involves this first, and it goes into the hand. And if I remember it right, I may be wrong, these patients have got clinical history of urinary tract. You can confirm that. I may be wrong, it's just I'm trying to think. I didn't look into it. But I think it's a syndrome. So either it's, I think it's urinary. They've got cystitis, UTIs, and they've got feet problems. So whenever you are going to diagnose writers, you look at the history, and they'll have history of UTIs. So again, I've written this, but what was the abnormality? Can anybody tell me? Yes. So you've got this talus. I told you it should be flat. It's completely flat. And look at the texture. You've got trabecularly. You can see the trabecularly. This one, if you compare this, is sclerosed. So what does it reflect? It's an AVN. So it's called Kohler's disease. So it's AVN, avascular necrosis of the navicular. Painful feet in children, always do a plain fill, and if you see this, this is ABM of navicular. This is what Gopi showed you. So this is the talus, and this looks like an adult patient, and this is still very prominent. So these are the ostrigone, and it has not fused, so you can see the lucent line. These should be the processes fused together with the body of the talus, and it is prone to infection, inflammation. Here, C2, here, here. So part of it is fused here, and there's still part which is remnant and it's not fused. So it's nicely seen on this. And these are the areas where you should be, they are susceptible to inflammation and infection. This is where it is. So you've got talus, which is got two processes, medial and lateral processes posteriorly, and this basically in childhood reflects ostrigone. So it's a background. It's an ossification center, and it fuses 8 to 13 years posterior to talus, and fuses with the talus within 1 year. 7% of the population remains separate and is referred to as the ostrigone. Again, the heel problem. You've got Ossicles. If you remember the writers I showed you, so it attaches in the superior and probably slightly posterior margin, but the erosions were here. So you need to know your anatomy. So Ossicles comes in and attaches on the posterior margin. So at the junction of the calcaneus and this insertion, you've got, this is calcaneus. It's the wording basically. If you know your antro, postro, latero, medial, so you can play your words. So this is calcaneus, and this is a bursa, so retrocalcaneal bursa. This is the calcaneum posterior process. This is the skin. This is the subcutaneous, so it's in the subcutaneous plane, so it is subcutaneous calcaneal bursa. This is Ossicles, so Ossicles inserted there. It can have avulsion injury here, and it can have inflammation here, Ossicles tendonitis. Again, it's important, and you can only differentiate this with a spec CT. Otherwise, you can see is how difficult it would be. If you've got avulsion of Ossicles or inflammation at the insertion, so that it doesn't mean that this is the only part which is going to be inflamed. It is going to take with it the subcutaneous tissue. It will take with it the bone marrow of calcaneum and the tendon itself. So this whole area will be inflamed, and this whole area will show increased uptake. So it becomes very difficult. So this is a nice presentation. So if you look at it, this is the bursa, and it's got inflammation there. This is the point where the whole thing will be inflamed, and the Ossicles is inserted there. So basically now differentiating between the insertion of the Ossicles and the plantar fascia. So you look at it, that's the tubercle there. So it arises from there, and it's inserted like a fan, and it goes and inserted into the base of the metatarsal here. So all four. So I'll show you another picture probably. So you need to be aware of where the insertions are, and then you can put in your report where it is. So again, nicely shows these are the slings which comes out and attaches along the metatarsal heads. So look at the insertion here and look at the insertion there, and you've got the normal bone in between. So that's the tubercle there. Calcaneum comes out as a body and then gives out slips and attaches there. And you can have medial and lateral thickening of the epineurosis. The osteochondral defects, these are very common and very sinister. It becomes very difficult at times to diagnose. But painful ankle can be reflective, it can be post-traumatic, or it could be just by minor injury. The most common place is, this is the medial part, that's lateral part, so lateral superolateral surface is the most common place. That's the cartilage, so you can have cartilage abrasion, then it can take off, just the cartilage can take off the bone, so you have got grading of these OCD. But we don't go into that detail. We can just say that there is loss and there is uptake and it's in the correct position, and on spec CT you'll be able to make a definitive diagnosis because you see the cortical irregularity or depression. So looking at it, you see this important thing is follow the cortex, and then you lose the cortex and it becomes like this. You have got sclerosis and there is low density area. So you've got small area of compression, that's grade 1, partially detached osteochondral lesion, so it gets detached. So that's 2, completely detached non-displaced fragment, the one I showed you, and detached and displaced fragment is 4. So we talked about the ossicles, and can somebody tell me what's written down there? So it's basically, look at the outline and the contours of the joint. You've got, instead of having a convex outline, you've got a flattened, loss of architecture there. You've got sclerosis. Whenever you've got at the joint loss, depression and sclerosis, it reflects necrosis. So Tribex is the head of second metatarsal, AVN. So all AVNs shows sclerosis with age. Bone scan with AVN is variable, probably you know better. So it depends which phase of the disease process you scan them. It may be hot, it may be cold, so it depends which phase you are scanning them. So the modality of choice is MRI. Thank you.